Hello and welcome to our next installment of the NovaSignal webinar series. My name is Robert Hamilton, co-founder of NovaSignal, and today I'm privileged to introduce our speaker, Dr. Nicole O'Brien. Dr. O'Brien is Associate Professor in the Division of Pediatric Critical Care at the Nationwide Children's Hospital in Columbus, Ohio. Dr. O'Brien earned her medical degree at the Medical College of Ohio and completed her residency and Pediatric Critical Care Fellowship at the University of California in San Diego. Dr. O'Brien has been using TCD in children with acute neurological illness and injury as both a clinical and research tool for more than 15 years. Clinically, Dr. O'Brien serves as a co-director for the Pediatric Neurocritical Care Research Group and specifically the TCD subgroup, where she has worked with key stakeholders to develop the utilization guidelines for TCD in pediatric critical care. Dr. O'Brien has also received a number of research grants to study the pathophysiology of neurological injury in cerebral malaria and bacterial meningitis in children in resource-limited settings. We're very excited for your talk today, and I'd like to again introduce Dr. Nicole O'Brien.
Thank you so much, Robert, for the really kind introduction, and thank you to the whole NovaSignal team for the invitation to be speaking with everyone today. So as Robert mentioned, I've got a specific interest in resource-limited settings. I actually spend 6 months out of every year in sub-Saharan Africa using TCD as a neurodiagnostic and neuromonitoring tool here. And then the other 6 months of the year in the US doing some clinical time. And so I am currently in Africa. If the power goes out or there are other issues, hang in there with us. I'll be back, but I'm really looking forward to spending some time with you and sharing about the experiences that we've had. I do have a couple of disclosures to make. These will become evident through the course of the talk. All right, so let's begin. In sub-Saharan Africa, a significant proportion of the overall pediatric morbidity and mortality occurs because of neurologic insults. In the setting of chronic conditions like sickle cell disease with its associated vasculopathy and increased stroke risk, or in the setting of acute central nervous system infections, most commonly bacterial or TB meningitis and or cerebral malaria. However, all hope really is not lost because if pathophysiologic changes to the neurovasculature can be identified in these diseases, there are proven or physiologically plausible interventions that can actually improve morbidity and mortality in each of these diseases. But unfortunately, while the kids that are at risk of these diseases on the continent are numerous, the necessary resources, infrastructure, and typical neuroimaging tools that are used to identify those pathologic changes to the neurovasculature really are not. And I think that's where TCD really has a unique role to play. It's got a number of positive attributes. It's very portable. In fact, this is actually me on a bicycle in a rural village in the Democratic Republic of Congo. Yes, I have a chicken on the front, but I think more importantly, I have a TCD unit in a backpack strapped to the back of that bicycle. So it truly is portable. It's comparatively inexpensive. Of course, it's non-invasive. What I love most is it also gives me real-time data in terms of what's happening with the neurovascular physiology, and I can easily repeat it for changes in the patient's clinical condition or to monitor a response to therapy that I've given. I've also seen it be exceptionally helpful as a diagnostic and monitoring tool in really the most austere of environments where families have to carry comatose children for long distances across hospital grounds, where we have to wait for the generator to be turned on and then literally do the TCD wherever we can find space, sometimes including outside on the porch with a big audience watching. Because it's so helpful, for quite a long time, I was trying to figure out how to operationalize this on a larger scale. And a couple of years ago, NovaSignal actually made a very generous donation of TCD units. And with that donation, I was able to apply for and receive NIH funding to open 6 transcranial Doppler ultrasound centers of excellence in sub-Saharan Africa. including 3 in the Democratic Republic of Congo, 1 in Malawi, and 2 in Zambia. So we had a number of aims that we were hoping to accomplish at each of these centers of excellence. First, really, we just wanted to design and implement a training course for African practitioners that would teach them the standard approaches to scanning and interpretation of TCD examinations that were relevant to this setting. Our second objective was to establish normal TCD values for African children. And then last, we have just wanted to start to build a collective database of TCD exams in kids with the diseases of interest, so sickle cell, meningitis, and cerebral malaria. So in regards to the first aim, over the course of a couple of months, we developed 12 didactic lectures that were heavily case-based and covered some of the basics: neurovascular anatomy, physiology, some basic scanning techniques, interpretation, and then also some disease-specific considerations. These were pre-recorded and available online. We also downloaded them all to USB flash drives, which were hand-delivered to some of our more remote locations so that practitioners could learn and study at their own time, independent of internet connectivity. Once all of the lectures were complete, everybody that had completed the lectures and then passed a written examination showing some proficiency in basic knowledge was eligible for hands-on training. This was quite an adventure sometimes. It meant long flights over the jungle, driving on roads that really were not roads, and then arriving to places that really had no infrastructure whatsoever. However, really no obstacle that we encountered was unable to be overcome. We started to travel more by motorbike with some of our equipment in cases on the back of that motorbike that allowed improved access to harder to reach places. We were able to carve out workspace in some of the local hospitals, give them facelifts, sometimes build our own furniture, and oftentimes purchase generators that would allow us to charge our TCD units overnight when we weren't using them, so we'd be ready to use them again the next day. And this approach has been exceptionally useful, and to date, we have over 40 African practitioners that have been trained on TCD use. They're actively using TCD for both clinical care as well as research purposes, and we're excited to say that we plan to just continue to grow. In the next year, we're planning to extend into Uganda, Kenya, and perhaps Zimbabwe. We consider this a huge success story thanks to Novasignal. Our second objective was to establish normative value for African children. So for those of you that don't do very much pediatric TCD, this is a key point. So cerebral blood flow, and therefore cerebral blood flow velocities, increase significantly throughout early childhood through around age 6 or 7 to accommodate that period of rapid brain growth and development. From there, then they decline through adolescence, where they reach adult levels by kind of mid-adolescence. And so when you are doing a TCD on an ill child and trying to interpret that TCD, it's imperative that you compare your results to published normative values. And it's only considered abnormal if those values fall outside of 2 standard deviations from the published age-matched normal. So of course, in Africa, there were really no normative values for what to expect in children. And so over the course of the first year of the grant, from churches, the villages surrounding, and schools surrounding our centers of excellence, we recruited over 700 normal children and did their transcranial Doppler ultrasounds. I think pretty definitively then establishing normal values for this patient population. And I just include this graph because it compares our results to what are commonly considered the normal pediatric values that other populations are being compared to, that were published by Bode et al. Back in the 1980s. And I put it up here because essentially in every major cerebral vessel for all of the measurements, we found actually significantly lower flow velocities than what had been described previously. And so whether this is environmental, nutritional, or genetic factors, or because of our significantly larger sample size, those original normative values in any population need to be considered. I don't know the answer to that, but I always just like to bring that up. And if anybody out there is listening and would like to really push forward and establish normative values in patients outside of Africa, I'd be happy to collaborate with you so we can answer that question. All right, and then on to our third objective, which was to start to build a collective database of TCD findings in the diseases of interest. So we'll start with sickle cell disease. Over 75% of the global burden of this disease occurs in Africa, where over 1 million children are affected, at least 60,000 of whom will have ischemic strokes because of associated vasculopathy every year. And pretty much in every other setting, TCD really is the diagnostic tool of choice for sickle cell related vasculopathy. It can detect its presence and it also grades its severity. And I think most importantly, if a high risk TCD exam is identified, preventative therapy with either exchange transfusions or chronic transfusions or hydroxyurea does result in significant relative risk reduction of developing a first ever stroke. In the case of transfusions, that is a 92% relative risk reduction if you identify vasculopathy with TCD and initiate that transfusion. But unfortunately, TCD use on the continent in Africa, despite the huge burden of disease, has largely remained stagnant until now, and we really hope to change that. But what we first found when we started to show up at the sickle cell clinics at each of the sites was that one major barrier was that the vast majority of kids being seen in each of the sickle cell clinics had actually never had a confirmatory hemoglobin electrophoresis, and were just diagnosed with sickle cell based on clinical symptoms, which is problematic for a number of reasons. And so we actually were able to do rapid point of care hemoglobin SS testing using the sickle scan tests. They have a 97 to 98% sensitivity compared to electrophoresis. And we were actually able to confirm diagnosis or steer kids in the direction of a different diagnosis if that was negative when we got this study started. Once kids had their sickle cell status confirmed, they then underwent their screening TCDs. And this is just a table of our results in our first 600 kids or so. I think we have almost 800 now. But I wanted to point out a few differences in our findings compared to those that were initially published by Bob Adams et al. In the initial STOP work in sickle cell disease in the United States. I think most notably, comparatively, we actually saw a much lower rate of abnormal TCDs, which was defined as a time average maximum of the mean of greater than 200 centimeters per second. But we actually saw a much higher rate of conditional risk TCD, defined as a time average maximum of the mean between 170 and 200. We also found a unique category that has been described in some other places in the literature, but not in the original TCD work in sickle cell. And that was another second abnormal group, which was we called time average maximum of the mean of a subnormal value, which was less than 50 centimeters per second in either the MCA or the terminal ICA. So really taken together, we really think that African children actually have a much lower rate of abnormal TCDs and a much higher rate of conditional TCDs and a very high rate of subnormal TCDs. But we do not have a lower stroke rate. In fact, it's actually somewhat higher than what was seen in the US. And so to us, this actually indicates that perhaps there are different TCD cutoffs and or other TCD parameters that might need to be used to most accurately predict stroke risk in African children with sickle cell. So for those of you that are not familiar with this graph, this is called Spencer's graph. And really, it just explains the relationship between vessel lumen diameter, cerebral blood flow, and cerebral flow velocity. So as that vessel lumen diameter goes down, you start to have blood flow that goes down, and accordingly, your TCD flow velocities will go up. Beyond about 80% lumen diameter reduction, that blood flow will fall off precipitously, as do your cerebral blood flow velocities. I think these kids over here with our subnormal time average maximum of the means probably represent a cohort of kids that have profound vasculopathy and are on the far side of the curve and therefore have an exceptionally high risk of stroke. But what else? What about all those conditional risk kids? They're up here somewhere. I think this is where our pulsatility index might actually be quite helpful. So your pulsatility index, or your PI, is calculated as systolic minus diastolic divided by mean flow. And a very simple way to think through it is, for any degree of vessel narrowing, if that blood flow is still sufficient to meet the metabolic demand of the brain behind it, your PI is essentially normal, nothing changes. However, if that blood flow is restricted to the point that the flow isn't meeting the demand, the small microvasculature will actually vasodilate in an attempt to get more blood flow. And as that happens, the diastolic flow will preferentially go up, and your pulsatility index will become quite narrow or low, which is what you can see on the bottom here. And indeed, when we looked at pulsatility index up here on the left of the kids with sickle cell disease compared to our normal values, we saw a significantly lower PI at 0.68 compared to 0.85 in the normal children. And then we also saw in kids with sickle cell disease that did not have a stroke history compared to those who did, another significant difference in PI up here at 0.74 compared to 0.54. And this set of images here on the right is a case example. So this is a 3-year-old child with sickle cell disease who underwent serial TCDs every 3 months. And you can see, based on her mean flow here at 90 and then 106 and then 141, she actually would have met low risk criteria for each of these exams. However, what was concerning to us was, if you look at the waveform, you can see some significant changes in the waveform with the diastolic flow coming up, and therefore your pulsatility index really falling quite drastically from 0.8 to 0.51 to 0.36. And unfortunately, this child suffered an ischemic stroke within a couple of weeks of this last TCD examination and actually died from that stroke. And so with all of that information, we actually are working on getting additional NIH grant funding to better define stroke risk cutoffs or other parameters in African children that actually truly portend stroke risk, so that we can try and help to give preventative therapy to those kids that are most likely to benefit. All right. Then on to bacterial meningitis, which is our second disease of interest. So again, this disease affects over 1 million individuals globally. And again, the highest burden of disease occurs in children in sub-Saharan Africa. Case fatality rates are between 8 and 15%, but I think real notably 50% survive with sequelae. And these relatively poor outcomes are largely attributable to various intracranial complications, of which stroke is one, ischemic stroke. And ischemic stroke occurs in 20 to 25% of kids with bacterial meningitis. Well, why is that? Take a look here at the right, and this is just a quick review of anatomy. Remember, your major cerebral vessels are actually running in your subarachnoid space. Your subarachnoid space is also where your inflammatory exudate in the setting of meningitis occurs. So that inflammatory exudate is rubbing up against those major cerebral vessels, causing vasculitis, vasospasm. I've seen actually enough purulence to cause external compression, mechanical compression of the vessels, and sometimes intra-arterial thrombosis. This was some nice work done in India, actually in kids with central nervous system infections. It was 110 kids. They randomized 55 to an ICP-directed group, which they achieved by giving hypertonic saline to target an ICP less than 20, or a CPP-directed group, which they targeted a CPP more than 60, and they got there by giving fluids and or vasopressors. I think really strikingly, when you pulled out the kids with bacterial meningitis and looked at their survival rates or their mortality rates, the ICP-directed group had a 40% mortality, where the CPP-directed group had just about a 10% mortality. And so a huge mortality reduction in the CPP-directed therapy. And the authors of this paper actually stated that they thought that significant difference was because that CPP augmentation overcame some of that fixed or mechanical obstruction that was occurring in the proximal cerebral vessels and decreased the stroke. However, I think in this setting, in resource-limited settings, indiscriminate use of CPP augmentation is costly, time-consuming, honestly not feasible. And it may be harmful, actually, in some kids. And so I think identifying the highest risk kids that are most likely to benefit is important. And so we did some work, looked at a small cohort of kids with bacterial meningitis. This is just their basic demographics. And I put it up there mostly because I think it represents similar demographics to what you would see anywhere in the world in terms of a cohort of kids with bacterial meningitis, with the exception maybe of the organisms. We do see Neisseria meningitis and Salmonella here. We, following enrollment, did admission and then serial TCDs on each of these kids who had bacterial meningitis. And again, when we think through kind of this Spencer's curve, and the degree of lumen narrowing, we weren't that surprised to see that across our cohort, about 21% of kids had panel A, which was a normal TCD. 43% of kids had high flow, but a normal pulsatility index. 15% had panel C, which was high flow with a narrow pulsatility index, implying some impaired perfusion. And another 21% had panel D, which was low flow across the board. But what was really interesting to us is when we looked at discharge outcomes, based on pediatric cerebral performance score. So those normal admission TCD pretty much universally having a good or a favorable outcome, whereas pretty much everybody that had low flow or high flow with a low PI had a poor outcome. And then I think of interest is those kids that had high flow, so they clearly had some degree of vascular involvement, but they had a normal PI, so they were still getting the perfusion that they needed. And I think, you know, this group here is probably the group that's most likely to benefit from CPP augmentation to try and aim to improve their outcomes. I don't think we'll have much of an effect over here if they start normal, and I don't think we'll have a huge effect if we start over here. This is just a case example of a 3-year-old that came in with strep pneumomeningitis. You can see flows are actually quite high, about 5 standard deviations above normal, and we have a very narrow pulsatility index down at 0.28. This was concerning to us, but the kid's neurologic exam wasn't horrible, but we were afraid that it was going to become horrible if we didn't make an intervention. So indeed, we augmented cerebral perfusion pressure by giving about 40 per kilo of fluids and then starting a low dose epinephrine infusion, and in addition to the antibiotics, of course. And within about 12 hours, we saw significant improvements in the TCD and essentially a normalization of the pulsatility index. And so we've got some future work planned to try and do a randomized interventional trial to direct CPP based on TCD findings in kids with meningitis, and sure hope that we get some favorable outcomes because of that. There are a couple of other considerations when it comes to meningitis. I don't think that most people in other settings would use TCD for this, but in this setting where we really have no other imaging oftentimes available, I do think it has a role to play in looking for and diagnosing both sinus venous thrombosis and obstructive hydrocephalus, which are very common complications of this disease. Why is that? Well, this is, again, is just a quick review of the anatomy. Again, your subarachnoid space is here. and that's where your purulent material is running. And so because of its proximity with the major sinuses, you're very have a significantly increased risk of inflammation and stasis in these areas, causing thrombosis. And then, of course, you've got your arachnoid granulations, which become occluded and can lead to obstructive hydrocephalus because they are in charge of cerebrospinal fluid transport. So this was a kid that had come in with Neisseria meningitis, and we were doing just kind of a screening TCD of the basilar artery, and basilar flows actually looked okay. The rest of the flows actually looked fairly good. But when we looked up here, we actually saw venous flow that was quite high at about 77. From our normal pediatric data, we know that normal venous flow, when you pick up a venous signal on TCD in kids, is roughly around 20. And so for us, we were concerned that this kid likely had a sinus venous thrombosis somewhere. We continued to follow it, but unfortunately his neurologic exam started to decline. And so we gave some extra fluids and started low dose heparin infusion under the presumption that this was a venous thrombosis. Within a couple of days, we saw that venous signal improving with flow down to 50. And within the first week, it had completely normalized down to 20. And this child survived without any neurologic deficits. In regards to obstructive hydrocephalus, this sweet girl is 4 years old, or well, she was 4 years old at the time of this picture. She came in with bacterial meningitis from strep pneumococcus as well. She actually had a normal TCD on admission. Her GCS wasn't terrible. She was probably between about 11 and 12. And we were gonna kind of leave her alone because she had a normal TCD. However, heading into day 4 and 5, we actually saw a declining GCS, and we saw her TCD waveform start to change. We started to see her diastolic flow really falling off, and her starting to have a very elevated or high pulsatility index, which we thought, given the clinical situation, was concerning for obstructive hydrocephalus. The reason for that is in obstructive hydrocephalus, particularly in the anterior cerebral arteries, but also middle cerebral arteries, you actually start to get stretch as those ventricles get larger and larger of the microvasculature. As you get stretch of the microvasculature, your resistance to flow goes up and your diastolic flow falls, increasing your pulsatility index. However, we couldn't really act on this. We couldn't get the neurosurgeons to act on this alone. So we continued to follow her. And unfortunately, the next day, we saw evidence of what we thought was even worsened obstructive hydrocephalus, where we were starting to actually have impaired systolic inflow as well. And based on this TCD, without any other imaging, the neurosurgeons actually took her to the OR, put an EVD in briefly, and then converted to a shunt. And she actually ultimately also had a nice outcome. So again, not things that a lot of people on this call will likely use TCD for, but I think it's always helpful to think of other ways that you might be able to use the tools that you have in front of you. All right, so we'll wrap up our time covering malaria. So malaria causes about 229 million cases globally and over 400,000 deaths. Again, 90% of those deaths occur in African children. The World Health Organization definition of malaria is a comatose state, which is defined as a Blantyre coma score of 2 or less. It's essentially a modified GCS. And evidence of Plasmodium falciparum parasitemia, and the absence of an other identifiable cause of coma. So essentially, you have to rule out bacterial meningitis, and you have to make sure the kids haven't been sneezing within about an hour of presentation, and they still have to be comatose. I included these pictures here because for those of you that don't take care of a lot of cerebral malaria, I'm a pediatric neurointensivist, and it is really a very striking presentation with lots of decorticate, decerebrate posturing. The kids really and truly are exceptionally neurologically impaired at the time of admission. And while the dogma forever has been that these kids are sick because of parasitized red cells, occluding the microvasculature, in the brain, I actually think the brains of these kids truly are a black box, and that I think TCD has a role to play in kind of unlocking that box. A couple of years ago, we looked at 160 kids with cerebral malaria, and we compared it to 155 kids with severe malaria without neurologic symptoms. And we were not particularly surprised to see that the vast majority of kids without cerebral malaria, so these kids mostly had severe anemia associated with their malaria, they had a normal TCD. But what we were a little bit surprised to see was rather than just a single abnormality on TCD, we actually saw 5 distinct changes to TCD across the cohort of kids with cerebral malaria, which we deemed and called in panel B hyperemia, in panel C low flow, in panel D microvascular occlusion, in panel E cerebral vasospasm, and in panel F isolated posterior high flow. These are kids that had normal MCA flows, but they had significantly elevated basilar artery flow. And each of these TCD phenotypes occurred at different frequencies. I think quite notably were associated with unique odds ratio of neurologic morbidity as well as mortality. To us, at least certainly suggesting that the mechanisms leading to brain injury in cerebral malaria are much more heterogeneous than just microvascular occlusion of those parasitized cells. We also did autoregulation testing using the transient hyperemic response ratio. It's no longer indicated or really acceptable in adults because of the risk of carotid plaque and embolization, but that's not really a risk in pediatrics, and so we're still able to investigate autoregulation in this way, which is you get a baseline MCA flow for at least 5 beats. You do a carotid compression for about 10 seconds, aiming to get at least a 50% reduction in your flow velocities. Then you do a rapid release, and then you divide the ratio of the flow 2 beats with levels of about 1.1 being considered normal autoregulation. And in our kids with cerebral malaria, regardless of their TCD phenotype, if they had intact autoregulation right here at 1.1 on days 1 and 2, their outcomes were significantly better than if they had impaired autoregulation on admission. But what I will point out is that autoregulation over time did improve, even in those kids where it was initially impaired, which to me seems to suggest that we have a potential therapeutic window here in the kids with cerebral malaria to maintain tight parameters around cerebral perfusion and hopefully prevent secondary neurologic injury. We just last year essentially repeated many aspects of that study in a unique population of African children also with cerebral malaria, this time 176 children. We found really a similar frequency of each of the 5 TCD phenotypes, similar associations with outcomes, and really the same impact of impaired autoregulation on outcome. But we weren't looking to just verify what we had seen before. We were actually looking to use the really extensive infrastructure that's been put in place at the Blantyre Malaria Project here in Blantyre, Malawi, to try and investigate what potential mechanistic explanations could be leading to these TCD phenotypes. So, for example, compared to normal, were our kids with hyperemia simply having higher cardiac output, or did they have increased metabolic demand because of fever, seizures, or acidosis, and that's why they had high flow? Were our kids with low flow just having low cardiac output? Were they in shock? Or did they have signs of increased intracranial pressure? Were our kids with microvascular occlusion just hyperventilating and therefore had low CO2s? Or did we have other signs of early increased ICP here? And so on and so forth with both vasospasm and posterior flow changes. And I know this is super busy and you can't really read a lot of it, but that's okay. Because the main take-home point here is none of the things that cause typical changes to TCD phenotypes, like what I just described, seem to be at play in this cohort of kids. So kids with hyperemia are not more febrile, they're not more anemic, they don't have higher cardiac index. Kids with low flow, while these numbers do seem to suggest their cardiac output is lower, it actually is still completely normal for a pediatric patient, and so is not likely the single causative factor of low flow. And those low flow kids had no increased markers of increased intracranial pressure based on opening pressure, optic nerve sheath diameter, or degree of brain swelling on MRI. So just for a few case examples, so this is a 5-year-old with cerebral malaria coming in with 3 days of fever, 2 episodes of seizures. Her TCD had some peak flows in the above 240, 250, which is more than 5 standard deviations above normal. You can see she's not particularly febrile. Her PCV, which is packed cell volume, is equivalent to hematocrit, while anemic was not horribly so, and certainly not horribly so in the grand scheme of malarial infection. She was not acidotic, and we had an EEG that did not show seizures. By hospital day 2, with supportive care only, her peak flows came down into the 180s, which is more than 3 standard deviations above normal, but improving. And then by day 3, peak flows had totally normalized, her coma had resolved, and she woke up and was eating and was out the door. This is an example of a child with vasospasm, small infant, again, presenting with cerebral malaria. On day 1, our right MCA peak flows were in the 180s, which for a child under the age of 1, again, don't forget to correct for age, were more than 5 standard deviations above normal. She had normal carotid flow, which gave her a Lindegard ratio of 4.5. She had normal left-sided MCA flows. Her vital signs are here, and I think most notably her MRI correlated with this. So you can see clear diffusion weighted changes in that vessel territory, significant edema, and we had an EEG that was also consistent with that, where she had right hemispheric suppression. And this child survived, but with left hemiapresis. This is an example of a low flow. This is a 4-year-old with cerebral malaria coming in with a couple of days of fever and seizures. You can see the TCD picture is here. Peak flows were in the 90s, which for a 4-year-old is more than 4 standard deviations below normal. The labs are here. This is essentially a slightly low but not terrible blood pressure for this age group. Opening pressure was 18, optic nerve sheath diameter was essentially normal. MRI brain volume score, which is how we measure cerebral edema in cerebral malaria, was just above normal, but not really anything terrible, no big, huge swollen brain. But we had seen enough low flow that we were worried about this kid. And so we actually decided to try adjunctive therapy on her and see if it made a difference. So she got 30 mLs per kilo of normal saline, also got an epinephrine infusion, and with those interventions on the same day, her peak flows completely normalized, her coma essentially resolved, and she survived without any gross neurologic deficits. And I'll contrast that with this case of low flow in a little guy, also with cerebral malaria. On admission up here on the left, TCD was grossly abnormal. MCA peak flows were in the 80s, which is more than 5 standard deviations below normal. Vital signs are noted here. Although I will say, we thought this kid had a shot at recovery because the brain MRI wasn't terrible in terms of the degree of edema. Opening pressure wasn't that high on LP at 20, and optic nerve sheath diameter also not that high. This is just a video of the initial TCD. Unfortunately, we didn't intervene on this one, and by hospital day 2, continued to have significant reductions in overall systolic flows with flattening of the diastolic flows and a widening of the pulsatility index. And we saw catastrophic cerebral swelling on MRI. And then by day 4, we actually saw reversal of flow, which is a pattern probably outside of the scope of this talk. And while you cannot use TCD to diagnose brain death in pediatric patients currently, it certainly is indicative of irreversible neurologic injury. And this kid, unfortunately, passed away. All right, so the last couple of slides here, I'm just going to close with a little bit of an update on what else is happening with TCD and cerebral malaria. There's currently a randomized interventional trial looking at hypertonic saline as a treatment option for kids with this disease. And I've been fortunate enough to be able to be at the bedside performing continuous TCD from before the hypertonic saline is given during the entire infusion rate up to an hour or 2 after the hypertonic saline is going in, which to my knowledge, I don't think anybody anywhere has had the opportunity to do that, because in other settings, the hypertonic saline is being given, you know, in the emergency transport, in the emergency rooms before they get to any settings where we would have the opportunity to do that. But I will put a little plug in here that, yes, I am holding the probe on this child's head with my hands for hours at a time, because that is the best way for us to get the data in the absence of pediatric headsets. So hopefully that will change moving forward. But across our cohort, it's a small number so far, but within about 30 minutes of starting the hypertonic saline infusion, all systolic, diastolic, and mean flows across the entire cohort, again, regardless of their initial phenotype, increased to an average almost of about 20% increase in our mean flows with the initiation of hypertonic saline. And this is a case example of a kid who I think it really, really benefited. This little guy is 3 years old, and he came in with flows that you can see here, means in the 50s, which again, for a 4-year-old are about 5 standard deviations too low. I think there's some other evidence of poor brain compliance on this, where you start to see your P2 signal here peaking up higher than your P1 at different points. We also did tissue oxygen saturations, and his tissue oxygen saturation was terrible at 30%, with a normal value of around 70% for kids. And by the time his hypertonic saline infusion had finished, his TCD had essentially normalized. Peak flows in the 130s, means close to 100, nice looking waveform here. And sorry for the quality of these images, but I was actually just taking screenshots with my phone while I had the TCD on his head, because I was just so excited to see such a drastic improvement with the hypertonic saline. And additionally, his tissue nears also significantly increased and essentially normalized up to 70s. So to be determined on the overall effects of hypertonic saline, but early results are certainly encouraging. I think even most encouragingly is this little guy that was looking quite rough at the beginning from a TCD and clinical standpoint.
What is he saying, Gloria? Go away. Why are you here?
Was doing much better and acting very age appropriate in a very short amount of time. And so with that, I'm just going to close. I want to thank everybody for joining us today. I want to thank you for your attention, and I'm happy to answer any questions or concerns that anybody in the audience might have.
Well, thank you, Dr. O'Brien. This is, I mean, first, congratulations on all the very, very important work that you and your team are doing. This is just amazing across not only the normative data set, but malaria and everything else that you're doing. So one, congratulations. There are a few questions. The first is, I think, regarding the normative data set, but maybe you can expand further. Do you think this can be really accomplished without the standardization of the technique and operator? It feels like normative data sets will always be kind of a range, given those variables that are well known in TCD.
Yeah, no, I think that's a great question. I mean, I think that if you can minimize the number of centers that are performing the normative assessments and minimize the number of operators that have already shown to have nice inter-rater correlation. So that's in fact what we did for the TCD norms. I probably myself did about 80% of the exams, and a number of the other people that had done the training, we had shown that we correlated really nicely on some standardized patients to kind of verify the quality of the data. I would encourage sites to do that if there's multiple operators trying to perform the normative data, and try and minimize those operators. But I certainly think it's doable, and I do think we can probably do better than enrolling somewhere between 7 and 18 kids per age group and calling that a normative value, which is what we're currently using in kids that are not African. And so there are limitations that you have to think about and address, but I think it still probably needs to be done.
Yeah, well said. One question, on that data, and I'm sorry if I missed it, but what do you see for no window rates? I mean, I know that's a common metric that's reported, but given the age of these children, what are you currently seeing?
Yeah, so I mean, I think our healthy kids, our no window rates are probably less than 2%. It's very uncommon to not be able to find a window. And those 2% are our older kids, our 12, 13, 14-year-old kids. The rate is higher in the kids with sickle cell disease. So in sickle cell, you get extramedullary hematopoiesis. So they get some frontal bossing, and it changes the shape of that calvarium, as well as the thickness a little bit. So I think our failure rates across all 6 centers for the sickle cell clinics is about 6 or 7%. And again, those are typically our older sicklers that have been having a severe disease for a long time. I think in our younger kids that are at the highest risk of strokes, who are under age 8, our failure rate approximates that of normal kids.
Regarding the ongoing clinical trial that you mentioned, can you speak a little bit about your expected kind of timeline for results or enrollment goals, or how does that look like for you and your team?
Yeah, so we are currently enrolling patients. I actually just was enrolling a patient just before I hopped on this call. We'll be enrolling patients through the end of June, and then we'll do some data analysis for the summer, and sure hope to have some manuscripts presenting the data out by fall.
Great. No, that's really exciting. I had some technical questions just on my my interest regarding some of the autoregulation testing. I'm not as familiar with the carotid compression versus call it some of the other methods used. Is that for simplicity, or do you find that things like non-invasive blood pressure and looking at something like MX or PRX would be better? It's just difficult given the situation.
Yeah, I mean, I definitely think MX, PRX are much better options. They're just not feasible in this setting. In terms of, continuous monitoring. We also don't do continuous ICP monitoring or continuous blood pressure monitoring. So those values really are impossible to obtain. In general, when I'm in the US, I definitely prefer those. So this is just a matter really of just what we've got available and trying to get a rough estimate of the child's underlying autoregulation. But it is fraught with difficulties. I think we only do it in the truly comatose kids. Otherwise, I think the values really are not usable. But in the comatose kids, we actually do get a nice carotid compression and I think pretty reliable results.
So I'm going to we have another question that came in. It says, have you done any work with robotic assisted TCD? Can this be used in children? That seems the best way to standardize techniques and do longer term monitoring. And this physician specifically says that might save your arms.
Well, I'll let you answer that one, Robert. No, I have not done any work with robotic TCD, although I am, of course, game to do robotic work with TCD and would love to see it expanded to this patient population. I think there are a lot of potential uses for it that would really push the field forward, especially in this setting where we have really no other monitoring happening.
Yeah, and I think that echoed one of the questions that I was going to bring up. You mentioned, pediatric headsets. Are there other areas of TCD specifically within pediatrics that you feel there needs to be advancements on? I mean, obviously, most of the work being done is in adults, and any thoughts on that, or requests to the field, if you will?
Yeah, I do. There were actually a group of us, a group of about 20 of us that got together a couple years ago and developed what we thought were essentially the consensus recommendations around TCD use in pediatric critical care. And I think as a group, we came up with several concerns that we still think need to be addressed. The lack of normative values is a huge problem. Another huge issue for us is because there have not been randomized interventional trials using TCD, the thresholds that recommend that indicate a need to intervene are completely lacking in really any disease condition, let alone exactly how to intervene and what impact those interventions might even have. And so really our objective of those was to standardize, and part of that is because even though a number of us are doing pediatric TCDs in critical care, the approaches weren't always standardized, the reporting wasn't standardized, it was difficult to compare across sites and centers. And so one of the objectives of those recommendations was to kind of standardize that so we could start to collectively dump data together to answer some of those key questions in terms of treatment thresholds and impact on outcomes. So in pediatrics, it really is a growing field, and we have a long way to go. And I'm super happy to talk to or partner with anybody listening out there that has an interest in pediatric TCD to try and push the field forward.
No, that's that again, just incredibly important work that you and your team are doing. I have one more question, from my side regarding kind of retinopathy positive patients, and I'm sorry if I missed it. Did you see any differences in those cerebral malaria patients that were retinopathy positive or not? I know that was of interest a few years ago, but.
Yeah, so I did not include that slide. So for those of you that are still on the call, there is something in cerebral malaria called retinopathy status. So there are retinal hemorrhages, retinal whitening, and some other changes that on autopsy studies were more clearly associated with malarial infection than those kids that did not have retinopathy. So to be clear, cerebral malaria is cerebral malaria regardless of retinopathy status, but it helps improve diagnostic accuracy. And so we do look, and the data that I presented here was all retinopathy positive cases. I do, of course, anytime you're looking at a cohort, it's about 50-50 in terms of who is ret positive and who's ret negative. So I have the ret negative cases, and I'm actually hoping soon to work on that comparison and get that published as well. There are not significant differences, though, at the bedside on the ret pos versus the ret neg. But I do think, because you are somewhat interested in cerebral malaria, I've looked at several hundred kids with cerebral malaria, and I always try and guess which TCD phenotype it's going to be when I go up to the bedside based on kind of the clinical situation that's happening in front of me, and I never get it right. You just can't tell until you put the probe ahead, which I think is why we're doing this and why we need to keep pushing this forward.
No, couldn't agree more. And again, I think that's all the questions we have. But congratulations on all your work. Thank you for sharing everything today. We do have one question that came in at the last minute here. Any embolic findings with these children? Great
question. Again, the thrombosis everywhere. Honestly, no. I see no microemboli really ever in any of the kids. If I do, I start looking for rheumatic fever or other reasons for their coma. So it's really not something that we pick up at all.
Great. Well, with that, again, thank you for your time. I know it's late out there, and glad hopefully everyone's safe after the cyclone. And best of luck with the continued enrollment and the work that you're doing.
And thanks so much to the team at Nova Signal for all the amazing support your team has given me. in our team over the years. It's just top notch, and none of the work that we would have been able to do would have been possible without you all. So heartfelt thank you from the heart of Africa.
Thank you very much.
All right, thanks.